Well, today is a very special day for the Department of Surgery. We are here for the inaugural William Pevec Lectureship. I'll start out by saying this is a great honor for me and for the whole department. Most of you know Bill, but for those of you who don't, Dr. Pevec, in addition to being a great friend, has been a great leader and, I would say, moral conscience for this department for a very long time. Listening to M&M this morning, which, by the way, we invited him to and he declined, which will be ironic for the people, or not maybe, for the people who have knew Bill's leadership in running our M&M for such a long time, but was always one to ask the question, what was your differential diagnosis? You know, helping us avoid what we now call anchoring or whatever it was. But Bill's the quintessential thinking surgeon. So those days when people, talk about things like the cognitive and the non-cognitive specialties, and that's just ridiculous. Surgery is a very cognitive specialty, and what you think about ahead of time is often the difference between life and death, as we saw this morning. So, Bill, your moral conscience, in addition to your technical prowess and your great patient care, live with us today. And so it's such a privilege to have had the Kenny family recognize your contribution to the care of their father and to name this lectureship in his honor for you. And we are so thrilled to have the inaugural professorship today. With that, Mark, if you wouldn't mind, I'd like to just take a minute to introduce Mr. McKinney's family. This is Mark and Patty. Patty, I'm going to make you stand up just while Mark says a few words. Thank you so much.
Wow, I will be very brief because you have work to do and you didn't come here to see me. This is not about me or my sister. Our father did not give his friendship or his trust easily, and he was more than happy to do so to Dr. Pevec. He never worried about his care. We witnessed amazing facility, amazing people, from the turn team to the surgeons to the people at the parking facility. Each of you has had a lifetime of service that brings you to this moment, and I want to thank you for that. I hope that you can feel the gratitude that we have for you, for this place. When you give a loved one back to the family, you restore a family and a world. And my wish is that that joy of that little doctor that started this journey is with you every day. And I'm going to hush, and I'm blessed to stand here. And thank you so much.
So with that, I'm going to, unless Bill, do you want to make a comment? You don't have to.
I guess I shouldn't.
I didn't.
Sneak away without it. But I just wanted to thank the family of Mr. Kinney for this honor and for this endowment that will continue the education of this fine department, and, as you pointed out, help bring the next generation of surgeons going forward into a higher level education. So thank you very much for that.
So with that, Dr. Mal, if you want to come to the podium to introduce our inaugural lectureship, who is very special to this department for many reasons.
Thank you, Dr. Farmer. It's really my pleasure to introduce Andy Schanzer as our inaugural speaker. Dr. Schanzer is from New York, went to Harvard for undergraduate, NYU for medical school, did his residency here at UC Davis, for those of you who haven't read the brochure, and was actually co-resident of a number of our faculty who are here in the room. He went on to do his fellowship at Brigham and Women's, and then joined the faculty at UMass. He became division chief about 4.5 years ago, and really since he's been there has developed one of the premier programs in complex aortic treatment. And so it's really our pleasure to welcome Dr. Schanzer back as our inaugural Pevec lectureship and to give us an update on aortic surgery. Dr. Schanzer.
Thank you very much. This really is a tremendous honor, and I also would like to personally thank the Kinney family for the opportunity. Let me see if I can get these slides up here. There we go. So I want to start by sort of highlighting that you are a product of your training. So this is no Photoshop manipulation or PowerPoint sleight of hand. I was young once, and this is where I learned to be a surgeon. And what I would say to all the trainees is soak it all in. Realize how fortunate you are to be at an outstanding institution. You will take many lessons with you that you are conscious of and actually not conscious of at this time. Along those lines, much of what I learned and carry forward to this day is taught to me by this person, Bill Pevec, who in contrast to my photo does not seem to age. Dr. Pevec taught me about vascular, but more importantly, and we talked a little bit about this last night, he taught me what it meant to be a physician, what it meant to be a doctor, and really what it means to be all in for your patients. And these are valuable lessons that I carry forward every single day. So thank you very much for that. I'm forever indebted to you for that, Dr. Pevec. So let me start. These are my disclosures. Today I'm going to be talking about the aorta. And, this is the area in vascular surgery that I really believe is the truly most amazing and most technologically evolving field, not only in vascular surgery, but I hope to make the argument in surgery as a whole. And we'll start with sort of dealing with more straightforward challenges like infrarenal aneurysms, juxtarenal aneurysms, pararenal. And then we'll transition and talk about thoracoabdominal aneurysms as well as arch aneurysms. In the way of background, AAA accounts for 16,000 deaths annually in the U.S. It's the 13th leading cause of death in the U.S., and it's the 10th leading cause of death in men over age 55. I think everyone in this room knows the natural history. That's expansion followed by rupture with growth of about 2 to 4 millimeters per year. So when we evaluate a patient, this is essentially the balance. We're looking at what is the risk of observation, that is the risk of rupture or the risk of death from rupture, versus what's the risk of repair, morbidity, mortality, and secondary procedures. And we've got pretty good randomized controlled data to inform that decision, with a consensus that 5.5 centimeters is probably the appropriate tipping point to start thinking about open repair or endovascular repair. So how do those two repair strategies work? Open repair, it's direct exposure, transabdominal or retroperitoneal. We get proximal and distal control by going above the aneurysm and below the aneurysm, and somehow we fashion a graft to suture into normal artery. And it's effective and durable. We've been doing it well since the 1950s when it was first designed. But there's 5 to 10% mortality in population-based studies. There's 15 to 30% significant morbidity. Recovery can be 2 to 3 months, and high-risk patients are often denied repair. And I put up these data just to highlight that we often think about these mortality rates of 1 to 2% at single high-volume centers of excellence like this one. But if you look at data extrapolated to the general population, that mortality from elective open repair is somewhere on the order of about 5%. And I want you to remember that number because that'll keep coming up during this discussion. So a transformative moment occurred in 1991, and that's when these two pioneers, one from Argentina, one from the Ukraine, first described endovascular aneurysm repair. Soon thereafter, 4 years later in 1995, these pioneers brought this procedure to the United States. And it's important to understand that endovascular AAA repair is a completely different concept than open repair. It involves exclusion of the AAA from the circulation. So a device is inserted from the groins, it's positioned with X-ray guidance, and then the aneurysm is excluded with a stent graft system. And in the United States, over 80% of infrarenal elective repairs of AAA were performed utilizing EVAR in 2012. Looking at the most recent available 2019 data set from Medicare, it's now up at 88%. So that pendulum has clearly swung. But I want to remind you that there's a fundamental difference. So with open repair, we can effectively deal with any aneurysm morphology. But with endovascular, you really need favorable anatomy. So I showed you this picture earlier, but you can see that here, with open repair, we cut the graft and we fit it to the aneurysm morphology to get to normal artery above, normal artery below. But with endovascular repair, you really need ideal anatomy. And I won't harp on the numbers here, but suffice it to say you need an area of normal aorta where you can seal proximally and where you can seal distally. And as you increase your deviations from ideal, you increase your chances for failure. We had the opportunity in a couple of review articles, one published last week, to sort of describe the current state with the pros and cons of open versus endo. And I'll try to just summarize that in one slide by summarizing two of the largest randomized controlled trials. So when you look at EVAR versus open, what we see is for EVAR, there's decreased mean operative time, decreased mean estimated blood loss, decreased blood products, decreased length of ICU stay, decreased overall length of stay, and most importantly, that last row, a nearly 4 to 5-fold reduction in perioperative mortality. But as we learned in this study and some others that I'll show you, when we roll these technologies out beyond the study context where patients are treated within certain anatomic boundary conditions, we see that patients can be treated differently. So in this study, we wanted to analyze a large, multi-center, prospectively acquired data set that was representative of real-world EVAR practice that contained extensive baseline and postoperative anatomic imaging data. And specifically, we want to ask the question, does compliance with the instructions for use for these devices predict outcomes? So whenever a device is approved, it has bench testing and then clinical testing, and it's done within certain boundary conditions of anatomy. But when these are then released to physicians, physicians have the opportunity to stretch those indications. And what we learned in this study is that 31% of patients in this data set of over 10,000 patients were treated outside of the most liberal instructions for use parameters. And what was really concerning is that 5-year post-EVAR rates of sac enlargement by a core lab was 41%, meaning that despite having an EVAR, 41% of these aneurysms were still growing. So it's clear that baseline aortic anatomy is a key determinant of EVAR appropriateness and long-term clinical success. And I think, bringing that question back to the clinical practice, why does this matter? It matters because we're starting to see a lot of patients like this in our practice. So this is a patient that had EVAR in 2004 with an aortic neck angle of 90 degrees, well outside the boundary conditions for any of the approved devices. And this patient did well until 2012 when he came back with a rupture and unfortunately died from that. This is another example with an aortic neck of 38 millimeters, so much larger than any of the approved devices. The vascular surgeon came up with a creative solution, mating a thoracic graft to an abdominal graft. Did well, but unfortunately came back with a rupture 5 years later. This is the last example I'll show you, although in our experience now we have 38 of these. But this is an EVAR in 2007. Again, aortic neck, large, highly angulated, outside of the boundary conditions. And you get the idea, this patient came back with a rupture. So I think it illustrates, first of all, that it's critically important to comply with these boundary conditions, but it also shows the impact of the need for really good long-term, lifelong follow-up. So how well do we do at that? Well, this is a study where we wanted to evaluate the rate of compliance with imaging follow-up post-EVAR and to identify factors associated with being lost to imaging follow-up. We linked data through 2010 from the Medicare inpatient, outpatient, and carrier files to identify all abdominal imaging studies that may have been performed for EVAR follow-up in just under 20,000 patients. And what we saw was that 50% of patients were lost to imaging follow-up by 5 years, and only 37% of those alive 6 to 8 years post-EVAR had an imaging study in the last 2 years. So clearly, compliance with imaging follow-up recommendations after EVAR in the US is well below the recommended rate. So for our division, we found ourselves at a bit of a crossroads. How to deal with this quandary that there's this 5-fold reduction in 30-day mortality if you use EVAR, but if you push the anatomic boundary conditions, you can actually have really disadvantaged outcomes. So I think one option is going back to open surgery. So doing more open surgery in the appropriate types of cases. And I think this is totally reasonable. But we felt that perhaps with newer evolved technologies, we could try to realize that 5-fold mortality benefit just using the right device for the right patient. And that really brings me to these photographs that I want to make sure take a little time to understand, because this will be the context for much of the talk. So the photograph on the left, what you see is called a scallop. That's just a cutout in the dacron of a graft. So you could imagine the renal artery sitting in a position where you could push that scallop and get a little more fabric to cover into normal aorta. In the middle, you see a fenestration. Fenestra is Greek for window. It's just a hole in the graft, which lets you now get fabric above and below the target artery. And then to the right, you see axial branches, which is just a cuff, works similarly to a fenestration, but has a little increased area of apposition. So again, it was our feeling that if you could take infrarenal aneurysm repair, which is fairly well tolerated, and realize a 5-fold reduction in 30-day mortality, then perhaps the real benefit of endovascular repair is in these more complex aneurysms, the 30 to 40% of juxtarenal, pararenal, and thoraco, because I think we all know that despite this being an operation that can be performed well, it's a big operation, it's a big exposure, lots of systemic stress. And if you look at this operation in the best of hands, so the 3 highest volume providers in the world with the largest 3 reports to date, you can see the 30-day mortality is not negligible, somewhere between 16%, 7%, and 8%. So certainly a gap and a room for improvement. And I think this should hit home because this is the California statewide inpatient database. So when you look outside of these high volume centers of excellence, a study by UCLA, and what they showed was that the overall elective mortality for open thoracosurgery was 19% at 30 days and 31% at 12 months. So what are the strategies for the endovascular approach to complex aortic disease? One is pushing conventional device limits. We talked a little bit about that. Snorkels, periscopes, and sandwiches. I hate this terminology, but we're stuck with it, so I'll go through that a little bit. And then fenestrated and branch technologies. So suffice it to say, we did not feel that pushing conventional devices into these anatomy that they're not intended to be used for was the right approach. So what's a snorkel, a periscope, or a sandwich? So let's run through that terminology. A chimney or a snorkel is the same thing. It's just a parallel stent to the main body of an endograph pointing down with inflow from above. So in this illustration, you can imagine a juxtarenal aneurysm where you can now get the fabric a little bit higher by putting snorkels into the renal arteries. A periscope is the opposite, so a parallel stent to the main body of an endograph pointing up with inflow from below. You can imagine a thoracic aneurysm extending down to the celiac, where you could put this periscope in and have some more fabric coverage inferiorly. But these technologies all suffer from the same Achilles heel, and that is gutters. That is a space between your parallel graft and the main body of your graft where you can transmit blood and thereby transmit pressure to the aneurysm. This is what it looks like in a patient. So here we've got tooth sheaths that are coming down from the left brachial artery. Here we've got the stent graft positioned in the target vessel, so coming from below is the main body stent graft with sheaths out into each of the renal arteries. We do a triple simultaneous balloon inflation and ideally end up with an imaging study like this where you see good patency of the renal arteries with complete exclusion of the aneurysm. This is one of the larger systematic reviews that have looked at the differences between open, fenestrated, and chimney repairs. And I'll just point out that when you look at the outcomes, there are disadvantages with chimney EVAR compared to fenestrated really in all categories, with, again, this main Achilles heel of a type 1 leak that is a proximal transmission of arterial pressure through these gutters of 10%. So the conclusion being that the technique should be considered only in acute poor surgical risk patients or in elective poor surgical cases not suitable for FEVAR, and I would agree with that. So let's talk about fenestrated branch repair, and we'll start off with this more straightforward types of anatomy. So this is a patient diagram that would have a juxtarenal or short neck infrarenal aneurysm. There's one approved device on the market for that called the Cook Zenith fenestrated graft. It's a modular device, and basically it includes 2 fenestrations for each of the renals and then a scallop for the SMA. So it gets you kind of one level higher of fabric, and the key is using a bridging stent graft. So what you're seeing here is a photograph down the barrel of that endograft, and you can see we've placed bridging stent grafts and then flare them to create a rivet across that hole to generate a seal. This is our first ZFen case from the pivotal study. This patient is now out 8 years, and you can see good anatomy with aneurysm exclusion. This was the initial pivotal study, 67 patients, a mean follow-up of 37 months, technical success 100%, 1.5% 30-day mortality, 81% primary patency, but if you intervene on these arteries with reintervention, you can get that secondary patency to 97%, 1.5% type 1 or 3 endoleak, no aneurysms, rupture or conversion, with the conclusion that ZFen is safe and effective, and the FDA approved this technology in 2012. We then did a study to look at the uptake of this technology, and you can see that really from approval in June of 2012, it took about 2 years to plateau at about 100 implants per month in this country. We recently published the 5-year data from this study, and the 5-year results confirmed safety and effectiveness with no late graft or aneurysm-related deaths. So let's increase one level, the complexity. So now we get to pararenal aneurysms, where not only does the aneurysm come up to the renal arteries, but now incorporates the aortic tissue at the renal arteries. There's one device that's been designed specifically for that indication. This is the P-branch device, which now has 3 fenestrations, so both renals, the SMA, and now a scallop for the celiac. What's kind of unique about this technology is that it has this P or pivoting branch, so there's redundant fabric at that renal artery fenestration, so you can target renal arteries within a 15 millimeter radius. This is the largest study to date looking at the results from the IDE study. 76 patients, 100% aneurysm exclusion, no 30-day mortalities, 1 renal sacrificed, and 2 renals unstented. This was our first patient in the P-branch study. This is the 5-year exit study. Again, you see kind of one level higher of coverage now with the renals, the SMA, and a scallop for the celiac. So now we'll transition and talk about thoracoabdominal aneurysms. There are several approaches to deal with these. There are physician-modified grafts, Cook, T-branch, Tambi, Medtronic, and custom-made devices, and we'll run through each of these. And we'll kind of go through this whole battery of the portfolio of devices that are currently available and coming to the market. So let's start with physician-modified devices. So this is a device that we take off the shelf. It's intended for another use, and then we actually cut the holes and modify that device to fit the patient's anatomy. So I think the first question is, what can we do with physician-modified endograft techniques? But probably the most important question is, what should we do with physician-modified endograft techniques? So let me show you a couple of clinical examples. This is a 72-year-old transferred from an outside hospital with epigastric pain radiating to the back, previous open AAA repair, and an ejection fraction of 25%. As we play this video, actually we'll just scroll through it. You can see as you get down to the level of the diaphragm, you start to see some retroperitoneal blood on the patient's left. Then at the level of the celiac, you see more retroperitoneal blood. At the level of the SMA, you see a clear rupture point. And then down at the level of just above the renals, you see that blush. And there you see some anterior angulation. So in summary, a patient that came in essentially with a type 4 aneurysm with a rupture. So we look at that patient on a 3-dimensional workstation. I make a drawing that looks just like this, where we sketch out exactly where each of the arteries come off, exactly what angle, exactly what position. We then open a device on the back table. We make measurements. We then make holes in the graft. We reinforce those with gold loops so that we can see them under X-ray. Sometimes we'll add these mini cuffs in order to increase apposition. And then we kind of scrunch it all up and put it back in its delivery system. This is now in the patient. You can see we've marked the SMA and right renals because those were stenotic. We then cannulate from inside the endograft, out the fenestration, into the target artery, and then ideally balloon mold that distal endograft into the previous open repair with proximal seal and filling of all the visceral arteries and a distal seal. This patient was in the ICU for 24 hours, discharged on post-op day 3, and now has 8-year follow-up and is doing well with a stable creatinine with good graft architecture and all of the branches patent. And we can take on more complex anatomy. So this is a type 3 thoracoabdominal aneurysm proximal to a previous EVAR with a right-sided aortic arch. That's relevant because the patient had had a previous right lobectomy, so was turned down for open repair. Here we've got sheath placed through the fenestrations, again for the celiac, the SMA, both renals. We balloon mold the fenestrated graft to his previous EVAR. We then put a stent graft into the celiac, the SMA, the right renal, the left renal. We then build the graft up to get a seal into normal aorta above, and ultimately a distal seal as well with good anatomy. So what can we do with physician-modified endografts? We can take on pretty complex anatomy, but what should we do? To answer that question, you really have to look at the data, and the data are somewhat marginal. There are case reports and technique descriptions, and outcomes and case series. So when you look at these case reports and technique descriptions, suffice it to say there are several of them. And basically, these are iterative looks at kind of how we can improve our ability to take the grafts out, modify them, and put them back in. And I would argue not the best way to disseminate a very complex technology with lots of people doing this iteratively at different places. This is actually the only prospective study. It's from Ben Starnes up at the University of Washington. And of note, this is just juxtarenal aneurysm, so no thoracoabdominal. 831-day follow-up, technical success of 95%, 12% complication rate, 2% type 1 or 3 endoleak, and 5.1% 30-day mortality, with the conclusion that PMEG is safe and effective, but longer-term follow-up is needed to assess durability. We did a study where we looked prospectively at 82 matched patients. So we matched these patients based on their anatomy, based on their comorbidities, based on their SBS risk score. And what we saw when we compared physician-modified grafts with custom-made company-manufactured devices, the outcomes were largely similar, except clearly there was more need for reintervention in these physician-modified endographs. So what should we do with physician-modified endograft techniques? I think it's a little hard to say because we really don't have long-term follow-up, but we're trying to build that up. But I think we can ask the question, is this the optimal strategy? And what I would say to that is that there are challenges inherent to physician modification. So first of all, there are issues of quality control. This is kind of airing my own baggage. This is a type of case you'd like to say was referred from someone else to you, but this was referred to me from me. So this is a patient that I built a graft for, so spent an hour on the back table. I put it in the patient, and I tried to open the graft, and I couldn't open it. So mind you, I've got the patient asleep, I've got both groins exposed, and I've got this device in the patient, I can't open it. So I took the device out, and I looked at it, and what you can see here, and I'm not sure how well it projects, but there's a stent strut that I got caught on the sheath when I reloaded it, and I could not overcome that force. Threw it in the trash, $10,000, made a new device, and fortunately the patient did okay. But again, I don't think I can ensure the same type of quality control that a company can with their QA processes in place. There's also limited customization because we're constrained to available devices that are intended for alternative uses. So this is a patient I've been following with a type 3 thoraco above a previous aorta by fem. I thought the patient got to the point where he warranted repair at 6.4 centimeters. But I want you to note that the main body of this aorta by fem graft was 18 by 9, so 18 millimeters in diameter. At the time, the smallest stent graft available to modify was 24 millimeters, so it's a lot larger. So we did the case. We got a 1-month CT scan. We high-fived because we had the aorta excluded. But then the patient came back for his 6-month scan, and we saw this. And what you see on the inside here are all the dots of the stents that is now massively infolded on itself, creating a big flute down the bottom with pressurization of the aneurysm. So again, we're trying to put devices in that really aren't intended for this use. We were able to sort of iron that out with a higher radial force stent, and the patient is doing okay now, about 6 years out. But again, not ideal. And there's his study after that. Time is a real issue, so I think we've gotten pretty good at this. But in our ID study, it takes us about 18 minutes per fenestration. That means for a 4-vessel case, that's an hour to an hour and a half of prep time. And you're taking a complicated case already and sort of adding this on. I think that has some disadvantages. And then finally, we talked a little bit about this, but there's a lack of standardization. So for physician-modified grafts, yes, we can do it. I think we need more time and data to tell if we should. And in my opinion, if an appropriate company-manufactured alternative is available, that likely is the best option. So let's talk about some of these other thoraco options. So the first one we'll talk about is the T-branch device. This was developed at UCSF, just down the road, has 4 downgoing branches, fits large thoracos very well where there's space to get out to the target arteries and where there are downgoing oriented arteries. This was our first T-branch case. He's now out 4 years. And you can see for the right anatomy, the branches lie very nicely. This is the largest study looking at T-branch, 73 patients, 18-month follow-up, technical success 92%, 4% 30-day mortality, although those were all in symptomatic or ruptured cases. Spinal cord ischemia, still the Achilles heel, 8.8%, target vessel patency of 99%, and no aneurysm ruptures or conversions. So let's look at TAMBI. This is now undergoing its initial pivotal study. This is a product made by Gore with a similarly 4 downgoing branches. Comes in a few different configurations, but basically is a 4 downgoing branch device where you cannulate things from above and put the device in from below. It's got some technical innovations like preloaded wires, which can make the procedure a little bit easier. This is the only study published to date, just the feasibility study, obviously 30-day follow-up only, technical success was 92%, no mortality, dialysis, or spinal cord injury, and 98% target artery patency, again, just 30 day. Next is the Medtronic Valiant device. I don't have any personal experience with this device. It's in its initial study now. There's nothing published on it, but you can see it's basically mating a number of different modular bifurcated devices together to kind of build down. So we'll see if that ends up gaining any traction. My primary experience, for the most part, is with custom-made devices where we can personalize a device and have it built specifically for a patient. There are 2 trials that are coming on this year, hopefully. So the first is a ZFen Plus trial with up to 5 fenestrations or scallops, preloaded guide wires, and low profile. And then hopefully scheduled for January of 2023 is the Cook Thoraco Plus trial, which is off-the-shelf 4 branch, as well as custom-made 3 to 5 branch. So our main experience is using these types of devices where we can actually specify to the engineers, build me this device for this specific patient. And this is just an example of a 70-year-old man with a recent MI, 7.4 centimeter thoracoabdominal aortic aneurysm, 3 subsequent hospitalizations for heart failure, turned down for open repair due to aneurysm extent and severe LV dysfunction. And when he came to see me, he had been turned down for 5 years, and it was that feeling that he'd been sort of going on for such a long time that his heart failure was probably stable enough that it was worth considering. So here you can see his CT scan, if we can get that to play. Relatively normal descending thoracic aorta, but as you get to the diaphragm, you'll see the start of this type 4 thoracoabdominal aneurysm. Pretty standard, large infrarenal component, and then good iliac access. So again, we put this imaging onto a 3-dimensional workstation. We create a 3D model of what the aorta looks like. We then have the computer put a center line through the area of flow so we can take every image we look at perpendicular to that center line of flow to understand exactly how the stent graft is going to interact with the aorta at every position. We measure their angles. I make a very sophisticated back-of-the-napkin diagram, but ultimately that gets converted over to our IDE study form. I send this to the engineers in Australia, and then they send me this, which is a lot more sophisticated than my drawing, which is called a spec diagram that I then sign off on and can order. And what I'll point out here is that everything can be customized, and that's really why I think this is probably long-term the best solution. So how long is the device? What's the diameter at the top? What's the diameter at the bottom? Do we want to have a taper in the middle? Do we want to use branches or fenestrations? We then bring the patient to the operating room. We start every case with a cone beam CT or a spin of the C-arm around the patient. That allows us to create a 3-dimensional model of the patient. So this right here is a 3-dimensional model without radiation. We're able to see exactly where the arteries are for easy identification without need for contrast and significantly reduced case time and radiation dose. Here again, now we've taken away that 3-dimensional model, but we've had the computer just put diamonds marking exactly where the origins are of each of those target arteries. I've put a wire in just to demonstrate the fidelity of that marker where the right renal is. We then cannulate the right renal branch, left renal branch, SMA branch, celiac branch, and ideally are able to show complete aneurysm exclusion. This patient was in the ICU overnight, stepped down on post-op day 1, discharged on post-op day 4, now has a completion CT. This was done in 2014, so he's now 7 years out with complete aneurysm exclusion, shown here on this run of the CT. As well as on this recon. So I want to shift gears for a moment and talk about the aortic arch. This is an area that has some very specific challenges. Great vessel perfusion is obviously critical. There's complex arch movement in multiple zones. There's a proximal landing zone that can be marginal. I'm told by the cardiologist that maintaining coronary perfusion is important, as well as maintaining valve integrity. So all those issues come into thinking about how can we deal with the aortic arch. I think it's fair to say that zone 2, 3, and 4 have largely been solved by TVAR, plus or minus some sort of revascularization strategy for the left subclavian. But zone 0 and zone 1 are more complicated, and we can basically embark on a hybrid repair strategy or a total endovascular repair strategy. So for zone 1, I think it's fairly straightforward, and hybrid repair works well. This is a patient we took care of that you can see saccular aneurysm. Interestingly, the vertebral comes off of the aorta, not off of the subclavian. So for this patient, we did a carotid bypass and transposed the vertebral onto the common carotid and placed a TEVAR, and this is what his reconstruction looks like after that. In zone 0, it gets a little more complicated. So this is a larger arch aneurysm now where you can see in order to get to normal aorta, you really have to be well into the ascending. So for this patient, we did a configuration like this where we did a median sternotomy, take a branch off of the ascending to the innominate, carotid subclavian. More commonly now, we'll do a bifurcated graft to the innominate and the carotid. And then you can see that we've got this endovascular chimney coming off in order to be able to deploy the graft at the time of that procedure because he had bad iliac access. So this is what that looks like in the operating room, head at the top, feet at the bottom. Introduce our TEVAR through that endovascular access chimney with the aorta to innominate bypass graft. This is the largest study looking at these aortic arch debranchings, 104 patients, very heterogeneous group, 29-month follow-up, 97% technical success, 5.8% 30-day mortality, 3.8% stroke rate, retrograde type A dissection of 3.8%, freedom from endoleak of 88%. But I think what's important to note is that landing in zone 0 had an 11-fold odds ratio of 30-day mortality, so still a significant problem when having to land there. So that gets us to total endovascular aortic arch devices. There are 3 that are currently being trialed. Gore has a single branch device on the left, Medtronic a single branch on the right, and then the Cook device, which I have the most familiarity with, which is either a 2-branch device or a 3-branch device. And this is what that looks like. So you can see these inner branches, and now we're more commonly using this 3-vessel branch device that has a retrograde branch for the left subclavian. This is an example, a 76-year-old woman, type A dissection repair with a Bentall procedure, had a reduced sternotomy for tricuspid and mitral replacement, then a reduced sternotomy for tamponade, then a right thoracotomy and decortication, but actually was still plugging along, living independently and doing well, and was referred in 2015 after being turned down for repair for progressive aneurysmal degeneration of the distal arch measuring up to 6.8 with 2-centimeter growth in the last 12 months. This is what her recon looks like, and the only feature I want to point out is you can see what made this a little harder is, I'm not sure if you can see, but there's a cabbage graft coming off of the ascending. So that left us with a pretty limited length of Dacron in order to seal proximally. So this gets to the edges of my PowerPoint skills, but this is just a diagram to kind of clarify the anatomy. Dacron graft, mechanical valve, cabbage graft coming off that dissection through the arch, dissection into the innominate. So pretty complicated. So we came up with a 2-stage repair strategy. So the first stage was a left subclavian to left carotid bypass with ligation of the proximal carotid, and then a right carotid to right subclavian bypass with ligation of the proximal subclavian. We then did a second stage repair where we put in a double branch device going into a seal above the dissection in the right carotid and into the left subclavian. This is what that custom device looks like. Interestingly, because of the mechanical valve, you can't cross that into the ventricle like you would want to get the support. So we're able to create a custom device that instead of having a nose cone, had just a bullet at the end. Kind of interestingly, which has kind of been fun about some of this journey, is they printed me a copy first. They made me a copy first, and then we 3D printed the aorta and tested it to make sure that it would fit. We then got the second graft and put that in the patient. Here you can see we've got a marking wire in the coronary to make sure we don't go too proximal and cover that. And then we've got wires coming down into the dots, which mark where the branches are from the carotid and the left subclavian. Now we've got our branches going up into the right carotid and into the left subclavian, and then did an angio showing that the cabbage graft's preserved, there's exclusion of the aneurysm, and good flow up to the great vessels. This patient's now 4 years out and doing well. This is the largest experience in the world with the double branch device. 54 patients, 12-month follow-up, technical success 84%, 30-day mortality 5.5%, and stroke rate of 5.5%. So still room for improvement. This is the largest study just recently published with the 3-vessel branch device, 39 patients, 3.2 months, technical success 100%, 30-day mortality of 5%, and stroke rate of 5%. So I'd like to tell you a little bit about our program. So we started our Center for Complex Aortic Disease back in 2008, really with an absurdly aspirational goal, and that was to become an internationally recognized center of excellence for the treatment of complex aortic disease, having never done a fenestrated or branch case to date. So, I was talking to some of the young faculty yesterday about this. I was able to reach out to Roy Greenberg, who's one of the fathers of this technology, who was really able to mentor me through this process. We've now presented our outcomes a number of times. Our IDE study is to evaluate custom-made devices and physician-modified approved devices for the treatment of patients with complex abdominal or thoracoabdominal aneurysms. We use an external clinical research organization that audits our books twice a year. We have an outside clinical events committee of 3 surgeons that review every adverse event, and we use a core imaging lab at the Cleveland Clinic to adjudicate all of our CT findings. And this was approved in 2013. We use fenestration, small and large, generally for narrow lumen aorta and upgoing arteries. We use branches in different configurations for large lumen aorta and downgoing arteries. You can see far and away the majority of our cases are done with company manufactured grafts. This was our last FDA data freeze at 379. We're now at about 410 cases. The point on the demographics that I'd like to highlight, because this goes back to some of our earlier discussion, about 23, so a quarter of our patients, 23%, are for prior EVAR failure or TVAR failure, again, kind of pushing the limits on these devices. Treated all types of aneurysms, from the most straightforward common iliac to thoracoabdominal aneurysms. When you look at the thoracoabdominals, 191 of them, sort of all Crawford extent. We've targeted 1,533 target arteries, with an average of 4 target arteries per patient. So these are generally 4 vessel repairs. Our technical success has been encouraging at 94%. We have had 23 intraoperative branch occlusions for a rate of 1.5%. Fortunately, none of those have been the SMA, which is obviously the most critical. We've been encouraged that in this group of complex patients, we've been able to keep our 30-day mortality below 4%. All of the other major adverse events are in the single digits, so we're proud of that to date. And I think what's kind of amazing compared to open thoraco is our length of stay is a median of 3 days, ICU 1 day, just patients that undergo lumbar drains. At 1 year, our survival is 86%, freedom from type 1 or 3 endoleak 89%, and target artery patency 93%. And while I'm proud of our individual results, what I'm really excited about is now having formed the United States Aortic Research Consortium. So I've had the opportunity to be the medical director for creating a collaboration between the 10 ID sites in the US. So this is 10 sites, all prospective studies, all independently monitored and FDA audited, and we all use similar devices. And this started as a pretty organic effort. So back in 2018, we started talking about how it would be nice to merge our data, but we all had our data sets a little bit differently. So we had a call every 2 weeks for 2 years where we went through all our CRF forms, all our adverse event definitions, came up with all these different modules, and then an Excel spreadsheet that said this is exactly how we're going to capture every variable, what we're going to call it. We engaged the FDA. The FDA was very supportive of this effort. We were able to get some grant funding, and after being able to raise about $3 million, we've created a center data coordinating core that's run out of the University of Alabama, Curso. It's all online now. We enter all of our cases exactly the same way. We can do real-time data analysis, and I think we can really push the field much further, all working together. And we've been able to start having some contributions. So this is 240 combined patients looking at post-dissection aneurysms, 564 looking at preloaded branches, 661 looking at target artery outcomes, 886 looking at gender differences, 893 looking at octogenarians, 893 looking at repair after infrarenal failure, and then 1681 most recently presented looking at secondary interventions. And you can see we've got a wide array of patients in this cohort of 1681. We're actually just broke 2,000 patients. But in this last analysis, what I think is pretty interesting is if you look at the 30-day mortality for 1,681 patients, it's 3%. And I, again, put that in the context of open aneurysm repair. And I think we've been excited about that. There is a challenge with this, and that is if you look at the radiation doses for procedures, endovascular thoraco repair has the highest recorded radiation doses. And that's concerning for patient safety, And more importantly, because we're standing at that C-arm all day, it's concerning for the providers in the room that are doing these cases. And I think we've all heard of physicians that have actually suffered cancer events thought to be secondary to their radiation exposure. For that reason, we're really excited to now be using this technology, fiber optic real shape, which instead of using x-rays, it uses a fiber optic cable that's actually embedded in the catheters and wires. This is what it looks like in our hybrid room. There's a workstation, there's an engine that's about the footprint of a bovie, and then it connects to the table. And I just want to show you really quickly what this looks like. So this is a 1-minute video. Here we're setting up the docking station. Now we're taking this catheter and we're plugging it into the system. We'll then take a wire, you'll see, and we'll plug that into the system. We then do a single x-ray of the patient and we register where that wire and catheter is in 3-dimensional space. And then we can fine-tune it to let it know the system exactly where it is. And now we're working without x-ray. So this is not with x-ray. This is a 3D model where we're pushing a yellow wire and a blue catheter into the SMA. This is real time. We're now pushing a yellow wire and a catheter into the celiac. Again, not using any x-ray, using a refresh rate of 2,000 times per second, where it's telling you exactly where that wire and catheter is. Here we're cannulating the right renal and the right fenestration. And then lastly, the left renal and the left fenestration. Then we're able to do a cone beam CT, which hopefully shows that everything is aligned properly. So we do this in the room with the current technology we have. And then this patient's 1-month CT scan. For this case, we have, in our first 21 cases, using this new fiber optic technology, we've been able to decrease our radiation dose 9-fold. So it's been a really nice innovation. In closing, the last thing I want to tell you is just because your group here is leading the way in this effort, we've started to try to capitalize on sort of our EMR and using better data science to identify patients with aneurysms. The vascular group here is going to be using the same technology in a couple of months. It's called Illuminate. We have a system now in our firewall where all clinical notes, all radiology reports flow into Illuminate. It then uses natural language recognition to identify patients that have aneurysms. It then tunes the system so it learns what your reports look like in order to create essentially buckets of patients that have different aneurysm sizes. And then this Acknowledge software package becomes a population health tool where you can reach out to these patients and follow these patients. And this is just one example of what the technology tries to do. It'll look through a note and it'll look at keywords, and then it will try to come up with a predicted positivity or negativity based on whether there's an aneurysm. We deployed this in January of 2021. We fed 243,000 clinical records into the system. It identified 5,400 aneurysms. And then just looking at bottom line, 32 of those cases have already had imaging, 20 are scheduled for imaging, 29 have had new clinic visits, 8 have had surgeries. There is a contribution margin associated with it, but I think most importantly, it's allowing us to follow these patients much better. So in conclusion, EVAR in appropriate patients is associated with excellent results. If we push the limits of conventional devices, patients will suffer. Evolving advanced technologies offer very promising results in highly skilled hands. The devices need to be simplified and access to these devices needs to improve. I've shown this slide for the last decade. During my career, I believe all aortic pathology from aortic valve to the femoral artery will be treated with stent grafts. And during my career, endovascular repair will be performed without the need for radiation. And we're able to do some pretty amazing things. You know, this is a patient that we treated with an arch graft mated to a thoraco device. And I think in some ways it's amazing that you can finish a case like this, put on Band-Aids, and call it good, discharge the patient on post-op day 2, 3, or 4. And while the Band-Aids are nice, what's really amazing is this. And this is a patient 7 days out from a type 2 endovascular thoraco repair. And the only reason I show this, and I could show you his imaging and pictures from his case, but I think you can see just from looking at him, there is not a patient in the history of open thoraco repair at any site on the globe that has looked like that at 7 days, coming in from home to clinic. And that's what really makes me excited about this. So going back to my title, it was lofty, the future is here, but I think it's fair to say it's not really necessary to look too far into the future. We see enough already to be certain that it will be magnificent. Once again, I really want to thank you for this opportunity. I am forever indebted to many of the people in this room for making me the surgeon that I am. Again, I'd like to thank the Kinney family. What a great contribution, and how wonderful to honor a person like Bill Pevec, who's had such a profound effect on surgeons like me, many surgeons in this room. Thank you all very much for the opportunity to present.
Well, I just want to start by saying, wow. Spectacular presentation, and I can't think of a more perfect person to have been our inaugural Bill Pevec lecturer. So thank you so much. We have a small token of appreciation for you
Beautiful.
with our little sort of DNA that hangs out in the.
I love it.
And I promise you that they don't think this is a weapon when it goes to
Perfect.
security.
Okay,
We've
good.
had it checked.
Well, I'm not giving it up. I'll just, I'll stay. Thank you very much. That's beautiful.
I'll tell you, it was Bill Pevec who told me, we're an ag school here at Davis, that I should stop giving people a bottle of olive oil because they couldn't take it through security.
Perfect.
So
Thank you.
Anyway, thank you again.
Thank you.
Really.
Very much. Thank you.
So we have a minute for some questions or comments, and then we're going to adjourn with the families to take some pictures out in the foyer later. But I do think we have some time for questions and comments. Dr. Pevec.
Fantastic presentation. Most fascinating part is that
I'm going to make you go to the, so that our people
fantastic
have a-
presentation. The most interesting, I think, from my perspective, is that fiber optic catheter direction system. So my question for you is, how close is that to commercial availability, and any idea how expensive it is? Because that is the Achilles heel right now for the operator, is amount of radiation exposure for these cases. So that is a tremendous advance.
Yeah. So I'll kind of try to give a brief answer on that. So first of all, there are two technologies in my career so far that have kind of blown me away that I've thought are absolutely transformative. One is fenestrated branch grafts, and the other is fiber optic wheel-shaped technology. So right now it has been rolled out at 3 sites in Europe, so Best, Utrecht, and Hamburg, and then we're the first site in the U.S., but they're ultimately going to have 5 sites in the U.S., 5 sites in Europe. And it is a first-generation device. And what I mean by that is it's quirky, but having said that, the learning curve is extraordinarily quick. So I didn't show this case, but my third case that I did with it, we're able to do all 4 branches with this technology and able to reduce the radiation in the third case by 6-fold. So I think it is actually going to totally transform the way we do these procedures. I think there are going to be med students that say to me, like, so come again, you're telling me you used to like press the pedal the whole time? And you'd be like leaning up against a C-arm? Because that's crazy. I mean, it's really crazy. So right now we're working on Gen 2, which is going to have some advantages. It's going to be catheter agnostic, so you can use any catheter. And then didn't have time to go into it, but I'm working with some of the companies about embedding these fiber optic markers in devices. Because right now you still have to fluoro the device. But you can imagine there's sub-millimeter precision. This was actually developed by NASA, the technology, and then bought by Philips. So the answer to your question about sort of how soon, I think within the next 5 years, it's going to have a more sort of global rollout. Initially, for the first 2 years, we're all putting all our cases in prospectively into a registry, and it'll be 10 sites. But then I think it's going to be rolled out. The expense is kind of interesting. So right now, because of a research partnership, we're not paying for it. But what they say is that they're going to basically charge 2x for the wires and catheters from what you're currently paying. But then there will be a capital investment to get that trolley. And they haven't really been transparent on where they're going to price that, so I just don't know.
Thank you.
So I have another technology question. You look at those graphs that you show, and I think, wow, that's not that far away from when, was it Stanley Crawford that was, his wife was sewing them in the,
Yeah, I think Dr.
bedroom?
DeBakey's mom was.
Yes.
Yeah.
That's right. DeBakey's mom made some of the first. It doesn't look that far away from that.
So
So where's the technology and advances going there? And are you lining them with anticoagulants or?
yeah, so I think that's a great question. So open aneurysm surgery, I think it's fair to say, aside from adjuncts, and the graphs haven't changed at all since the 50s. Endovascular, there has been significant innovation, but that innovation is not so much around kind of antibiotic stuff. It's more about how can we get something relatively large, really small. So they've taken the fabrics and done different types of weaves where now you can have ultra low profile. We started off using grafts that all had stainless steel stents, but now we use nitinol because it can be packaged much smaller. And I think, I didn't have time to go through this, but kind of the evolution of these devices, they used to be 24 to 28 French. That's really big, like think about chest tubes. And now everything I use is ultra low profile fabric with nitinol. So the biggest I use is 18 French. And for the vascular surgeons, I mean, that compares pretty favorably to the routine EVAR devices. So I think the innovation has been more around kind of packing density than kind of changes in the fabric.
So I assume everybody has to be anticoagulated?
No. Yeah, so we give everyone, so they get anticoagulated during the procedure, as you would normally. But then they get 3 months of dual antiplatelet and then just lifelong aspirin. Yeah, so Plavix for 3 months.
Yeah.
Any other questions?
Dr. Rodriguez.
Sure. I just want to make a comment and ask a quick question on it's amazing to me to see how well you've done for yourself.
That's very generous.
We are very proud of what you've accomplished, and so thank you very much for coming by and
Little old Davis
sharing
guy,
this.
right?
Exactly.
I
mean,
just
I can
chased him around. He was my chief. I just tried to do whatever he told me.
I can remember doing
You're the
open
best.
thoracoabdominal aneurysms with you at Kaiser when we set up the aortic program there. I was given a talk at one of our, I think it was UC Davis surgical meetings that we used to have here, and right after my training in Madison, Wisconsin, it was an endovascular aneurysm repair, and Dr. Blaisdell gets up at the end of the talk and says, "Victor, if you ever have to do an aneurysm repair on me, I want you to cut me open." So then flash forward, I'm at Portland, Oregon, and Dr. Maneda tells me, "Victor, you're a dinosaur." Sherry Abrams was just hired there. He says, "You're never going to be doing thoracoabdominal aneurysms repairs again." And now you're telling me that that is actually the case. Am I a dying dinosaur? Should they take me out to pasture?
No comment. No, I mean, I guess I'll say two things. One is all of this stuff can be done successfully with a strong partnership with cardiac surgery. And I really mean that because it's a synergy that you need to be successful. And looking at a lot of programs around the country, one of the failure points is cardiac surgery trying to do it or vascular surgery trying to do it. Because you really have to work together. So a lot of the stuff I didn't really go into is kind of preparing the arch in order to be able to put stent grafts. Landing in Dacron is the best proximal seal you'll ever get. And then, is there a role for thoraco? There is. Young people, connective tissue disorders. But I guess I would say, respectfully, the future, I believe, is these technologies. And it's because of that last picture I showed you of that patient. I mean, Victor, you're an amazing surgeon. You take great care of patients. But the technological innovation with the recovery from these types of procedures, when they go well, and not all of them do, is just so markedly different. And that's why, in my opinion, the EVAR for infrarenal aneurysms, yeah, there's a role for it. It's important. But we're really conservative. We do a lot of open infrarenal repair. But thoraco is where the tremendous advantage is. Because when you put these patients through those operations, I believe at least, they're not the same afterwards. It's just a big, big thing to go through.
So how do we train our trainees to do open thoracals if I'm going to be gone firing? So what's going to happen with all these? How are they going to do it?
Yeah.
How are they going to do it?
So in all seriousness, that's a really big challenge. And that is not an answered question. I do think that open thoracosurgery is still going to have a role, but it's going to be super regionalized. And it needs to be. Because there's just no way that many sites are going to be able to do open thoraco well. So I think people are going to have to get special training in open thoraco, and they're going to have to be at special sites to do it.
Check them out.
Andy, that was really a phenomenal talk. Really, thank you again for accepting our invitation. My question to you is about the custom-made grafts. I mean, what a great opportunity you have to have so many of these being treated with custom-made grafts. How far away is that, or is that even, in the horizon for other institutions to be able to get those custom-made grafts built, either inside or outside of an IDE? Because it's my understanding that even now with IDEs, the new IDEs, that may or may not be available to surgeons.
Yeah, so that's a great question. I think we are closer, but we're not there yet. So right now, there are only 10 sites in the U.S. that have access to these devices, and that's absurdly low. I mean, it needs to be more than that. The good news is, and I'm sort of involved on the planning committee for this, Cook is going to roll it out to 15 additional sites, and that'll bring it at least up to 25. But for the first time now, we actually have some real concrete trials underway. So TAMBI has enrolled really well. So that's that 4 downgoing branch device. I think you'll probably have access to that within 2 years from now. And then the Cook ZFen Plus trial and the Thoraco Plus trial, we've already submitted the IDEs to the FDA. I was on a call with them actually on Wednesday about it. So that trial will start, ZFen Plus will start this calendar year. Thoraco Plus will start next January. So I think at least now we're getting to the point where there's going to be some more dissemination. Going back to Victor's point, though, on the open side, the endo side, the training's a real question also. But I think that it is much easier to get people trained up and for a system to be robust enough to be able to do the endovascular complex thoraco work than it is the open complex thoraco work.
Well, I just want to thank you again, and also, thank the Kinney family for your generous contribution to honor Bill. I also want to congratulate you for bringing out some of our old friends. Dr. Wisner trying to sneak out the back door there. Dr. Holcroft.
He's got to go put in a chest tube.
So really thank you again.
Well, it's an honor to be here. Thank you very much, and thank you very much for making this possible.